Hi, my name is Dr. Adam Wegner. I'm a board-certified orthopedic surgeon with OrthoVirginia. I see patients at the Arlington office and our McLean-Tyson's office. I'm trained in spine surgery. I did a fellowship in both pediatric and adult spine deformity surgery, specifically interested in scoliosis. And I've been in the DC area now for about a year and a half with OrthoVirginia. And so I'm specifically interested in both scoliosis and revision surgeries after previous spine surgery. And so since this is Scoliosis Awareness Month, we wanted to try and do this Facebook Live to remove some of the mystique around scoliosis and debunk some myths that patients potentially have heard about scoliosis and usually cause some anxiety for patients and families. So patients who have scoliosis usually come to see me from either their pediatrician or their primary care doctor. And between that referral and when they see me, they're often worried, did they do something to cause this? How is this going to impact their life? Is it going to be painful? Are they going to need surgery? And generally just scared. And so hopefully this information today will help you not be so anxious once you're diagnosed with scoliosis. And so I'm first going to go through the different types of scoliosis and then debunk the 5 different myths. And so there are about 7 million people in the US that have scoliosis. And so that means that almost all of us either has someone in their family or in their school or in their friend group who has it. And oftentimes you may not even know someone has scoliosis. The official definition of scoliosis is an abnormal curvature of the spine. And so you measure the most tilted vertebra, and if it's more than a 10-degree angle, it's officially scoliosis. Classically, when we think about scoliosis, it's from looking at someone from the back, and you see sort of an S curve in their back. And this is also how we look at x-rays. But it's really a 3-dimensional deformity, and we're starting to appreciate more now how when you look at from the side, the curve of your spine from the side also matters. And actually the vertebrae rotate as well. And so you really need a 3D view to fully appreciate a curvature in scoliosis. And one thing that's important to know is that scoliosis is different in kids than it is in adults. And so oftentimes we think about teenagers being diagnosed with scoliosis, but I'll go over the different types. And so most commonly we think about, an adolescent who has a curve, and it's most commonly in girls from 10 to 18 years old. Most of the time it's diagnosed at a school screening or by the pediatrician, and most of you may have either gone through this or heard of this, where you bend down towards your toes and you look for an asymmetry either in the thoracic, the chest wall or the low back. And the reason there's an asymmetry is because of that rotation I talked about. So the spine curves to the side and also rotates, and so one side is higher than the other. And so if they see that, then they'll refer a patient for x-rays and then eventually to me. There are a few other types of scoliosis that aren't as common that I'm not going to talk about today. So you can have a congenital abnormality of your spine. There can be early onset versions that happen even as less than 1 year old. And there are neuromuscular conditions like cerebral palsy and certain syndromes that cause scoliosis. But the most common type of scoliosis that's diagnosed in the teenage years is adolescent idiopathic scoliosis. And so that happens, when you're a teenager. Usually, the curve as the patient grows, and if you stop the curve before they get to the surgical range, which is usually about 45 or 50 degrees, and then you don't need to have a surgery and you can live your life normally. And then there are some people we can talk about will eventually need surgery, but that's relatively rare. There's also the version of scoliosis where you're diagnosed with scoliosis as a kid and you have that adolescent idiopathic scoliosis, and then you grow up. And so there are adults in their 40s and 50s who I see for the first time who would get an x-ray, and maybe they got a chest x-ray or something, and they see a curve, and I can tell them, well, this happened when you were a teenager, and you've been living your whole life and doing everything normally, and so you can probably continue to do everything normally. Maybe we need to check this every couple of years. There are also patients who are adults who have had surgery for scoliosis as a teenager that would then also follow to make sure everything is going well. And then the final type of scoliosis is the adult degenerative scoliosis, and that's a completely different set of patients. And so that develops later in life, in the 60s, 70s, or 80s. And unlike AIS, this one is painful. And so it's because you can get nerve compression from disc degeneration and bone spurs, and it can cause leg pain from the nerve compression, and you can get overall global deformities. Whereas as the scaffolding of your body, the spine is sort of falling to one side, you can start to tilt all the way to the side, or you can start tilting forward. Unlike the adolescent version, where generally a patient is well aligned, their head is over their hips, both from the front and the side, but they have a curve in the middle. And the adult version of scoliosis is very debilitating. It can be as debilitating as chronic diseases like heart failure or lung disease. So it's a very different way of thinking about patients when it's an adult with degenerative scoliosis versus the idiopathic type. So now all scoliosis curves aren't created equal, and I'm going to go over several myths about scoliosis. And the first one is that people always think that are trying to find something they maybe did that caused scoliosis. And so the middle word in adolescent idiopathic scoliosis is the key here. Idiopathic is the word we use for we don't know what causes it. We spent a lot of time and money trying to figure out what causes scoliosis. We think most likely it's an abnormal growth, an asymmetric growth of the spine that causes the curve. Usually we know there's some genetic component to it. There are often many females in the family that have scoliosis if there's a diagnosis, but we've never identified one specific gene that causes it. But people often wonder if slouching causes scoliosis. Teenagers often are on cell phones, laptops, and studying. There's never been any association shown between posture and scoliosis, and so you can do something that caused this. I always tell people that if slouching caused scoliosis, every teenager would have scoliosis because it's so common. It's not caused by carrying heavy backpacks. Again, every teenager carries a heavy backpack, and that's never been associated. There's no specific sport or sports injury that causes it. Some people are wondering, well, if I play the violin and always turn to one side, does that cause it? And there's no association between any, instrument and scoliosis. One other common myth is that a leg length discrepancy causes scoliosis, and that goes back to thinking about it only in the one plane. If you look at someone from the back, they have the S curve, and if one of the legs is higher, you can imagine that maybe causes the spine to be curved. But if it's a true scoliosis, there's also the rotation and the sagittal plane issues that wouldn't happen if there's a leg length discrepancy. So the leg length discrepancy will cause the spine. You have to have a small curve to correct for that, but it doesn't actually cause scoliosis. And then in the adult degenerative version, usually also not one specific thing. It's not like you sat at work your whole life or had a sports injury or a fall as a child. It's usually just normal degeneration with time. And that's multifactorial. It's your genetics and it's what you've done in your life. And so some people live very strenuous lives and have minimal degeneration and a completely normal looking x-ray. And there's some people who live very mildly strenuous lives and have a big curve because they have severe degeneration. That's there's usually a genetic component to it. And so the second myth is that scoliosis is going to significantly change my life or will stop me from doing what I want to do. And I try and emphasize with my patients, especially my pediatric patients, number one, generally these patients don't have pain, and they can do anything they want to do in life. And so if you want to play a sport, there's a professional female golfer who on the LPGA tour had a scoliosis surgery. You can really do anything you want. There are kids who have scoliosis surgery and play football, and so certainly if you don't have surgery, we're not going to limit you from doing any activity at all. One question that parents often have is about having children in the future, and I always tell people that has absolutely zero effect on anything in the process of having kids. One thing it may affect mildly is if you get an epidural. Remember, there's the rotation, and so if you do have a curve in your low back, the anesthesiologist just has to be aware when they put the epidural in to put it in the correct the correct direction to get into the spinal canal. But otherwise, it shouldn't affect anything in the process of having children. Even if you have surgery, it will affect some motion and, some ability to do some things, but kids are very resilient and generally it doesn't affect their ability to do any activity. Like there are kids who dance and like I said, play football after scoliosis surgery. And so, the other thing is people assume scoliosis is painful. And so this is partially to remember because I talked about the two different types of scoliosis. The adolescent version generally isn't very painful. I would say 99% of the patients I see with a curve in their back who are teenagers don't have any pain. And where they do often have discomfort is usually the right scapula. If you have a curve in your right upper back, is a little asymmetric. And so sometimes there's some discomfort there, and oftentimes you can do physical therapy or take medications that can help with that discomfort, but it's not really painful. And the other thing that I mentioned is the surgery. If we do surgery, which is not very common, it's not for pain, unlike the adult version that is for pain. And so I always tell people that if you have a surgery, you may actually have more pain than before, because if you had no pain before, now you've had a spine fusion and you have some scar tissue, there's always the chance of having some pain in the future. And so the reason we do surgery in teenagers with scoliosis is to stop progression. The main goal is to make sure the curve doesn't get worse. So if you have a big curve, that's getting up to 45, 50 degrees, we know those curves long-term may progress even when you stop growing, and we don't want that to happen. Or if you have a big curve that's that big and we know you're going to grow still, we want to make sure it doesn't get too big before we stop it from getting bigger. The other benefits of surgery, like I said, is not for pain relief, is, you do decrease some of the rotation, so you can decrease some of the asymmetry of the trunk. And so there's a cosmetic component to it. Maybe you'll be slightly taller because as you take a curve and you straighten it out, you get a little bit taller, although I never guarantee a certain amount of height gain. And then in severe cases, I'm talking about curves that are really big, like 80, 90 degrees. There is some effect on lung function if it's a thoracic curve. And so by straightening that curve, you can improve lung function. But most curves we see that are, in the 30, 40, even 50 degree range don't affect lung function. And it doesn't compress your gastrointestinal system. It doesn't affect your stomach. It doesn't affect your kidneys. It doesn't affect your liver. Those all function normally. And so you don't have to worry about it affecting any of those other things in your body. Like I said, the adult degenerative version of scoliosis is where you have a curve from degeneration of your spine in your 60s, 70s, and 80s. It is painful. You get leg pain from nerve compression. You get your muscles can get very fatigued from trying to compensate for that. If your scaffolding is crooked and your muscles are trying to pull you back up, it can be really painful and really, really tiring to try and stand up straight. And sometimes people have to use even a walker or a cane to try and stand up. And one painful part of that is also if you fall far enough to the side, your ribs can hit your pelvis, and that can also be really painful. Another common myth, I think, in scoliosis that people are often worried about is that they think, because I have scoliosis, I'm going to need surgery. And that's just not true. Most of the time, scoliosis does not require surgery. And like I said, it's the curve side is all that matters. And so if someone comes in with a curve of 45, 50, 60 degrees, which is most of the patients are in the 10 to 30 degree range. If you do come in with that big curve, we may have to discuss surgery. But a majority of these patients, we don't have to do a surgery. Risk factors for needing surgery would be as if you present with that big curve, or you're very young and have a lot of time for your spine to grow, because it's that growth that can potentially cause the curve to get worse. One very effective treatment we have for scoliosis that is non-surgical is bracing. And approximately 30,000 kids get braced for scoliosis every year. And that's for kids that have 20 to 25 degree curves that are still growing, because we want to make sure as they grow, the curve doesn't get worse. And I have a tight collaboration with the National Scoliosis Center in Fairfax, which is really a spectacular place. They only make scoliosis braces. They're very skilled at it. There are very few places in the country that only do scoliosis braces and are this good at, and this hands-on at doing it. You get to go and pick your own colors. You watch the whole custom brace process, and then they follow you very closely to make sure it's fitting well and that you're wearing it correctly. And so it's an incredible resource to have in the DC area. The other treatment that has been studied but has not really been proven yet is called Schroth physical therapy. Regular stretching and strengthening physical therapy has not ever been shown to decrease progression of these curves, but Schroth therapy is currently being studied to potentially decrease the progression of curves. I don't think I would ever recommend therapy alone in a curve that I think needs to be braced. That's the one thing that's been shown with a true randomized trial to not to stop progression of scoliosis. And so if your curve is in the bracing range, you absolutely have to brace to decrease your risk of surgery. But sometimes we add the Schroth physical therapy to help strengthen the core muscles and potentially decrease the risk, and that's still being studied as an adjunct. Unfortunately, adult curves are not as easily braced, because braces are designed to stop progression in growth. And you're getting global deformities where you're falling to the side or forward. You'd have to wear a brace essentially through your entire body to keep it straight, and you can't really stop the degeneration. So braces don't really work as well in adults with degenerative scoliosis. But again, adults, sometimes an adult discovers they have scoliosis on an x-ray and they have no pain. And so if you have a curve with no pain, you're not symptomatic, sometimes you need to do nothing. You just need to watch the curve every couple of years with an x-ray. And we have many non-surgical methods for helping to deal with the pain, such as physical therapy, medications, epidural injections, activity modification, and surgery is always a last resort. Only when you've exhausted every other option and you're still having pain or you're still debilitated enough that it's worth taking the risk of surgery, do we discuss a surgery? And so the final myth is that scoliosis is scary. And I think if you add up all of these myths from the previous 4 myths, it could be scary if you didn't know the answer to those questions. But now that you know, hopefully you'll have less anxiety. Everyone is very nervous when they come to see me and they've had this diagnosis. And hopefully now I've convinced you that it isn't necessarily as scary. If you have adolescent idiopathic scoliosis, you'll be able to live your life normally. You'll be able to do anything you want. Most of the time you won't need surgery. You may need a brace. And then adults who had scoliosis as an adolescent and are now adults, you've lived your life this long, you've done everything you've wanted to do, and hopefully we'll be able to allow you to continue to do what you want to do. And maybe we need to tune things up with physical therapy or some medications. Almost everyone has back pain at some point in their life. The studies do show that people with idiopathic scoliosis may have a slightly increased risk of back pain in their lives, but it's hard to know what's just back pain you would have had anyway, or back pain that's from the scoliosis. And so generally people with adult idiopathic scoliosis are relatively normal and active. And then again, the adult degenerative version is a bit different. It's more debilitating, but we have many techniques, both surgical and non-surgical, that will hopefully, will help you improve your quality of life. And so thank you for taking the time to join us today, and I'm happy to take any questions.
Thank you. We will be answering some questions submitted earlier and some questions submitted now. So please feel free to put your questions in the comment section. Our first question is, if a child has been diagnosed with scoliosis, for example, from their pediatrician or from a school screening, when should they see an orthopedic spine surgeon?
So I generally advocate that they should probably see an orthopedic spine surgeon if there's any question at all. I think that because there's the anxiety surrounding it and because you don't want to miss something with your kid, I usually say bring them to our office. We'll get a full-length x-ray to see. Sometimes x-rays are variable in different places and different people read things differently. And so because we do this every day and it's all we do, I think we can give a much better assessment, more standardized assessment of scoliosis, and answer all of your questions as fully as you want them to be answered. So I would never fault someone for coming to see us if they have any concern for scoliosis at all. And just because you're going to see a surgeon does not mean that we're going to be talking about surgery. I almost never talk about surgery the first time I see someone. And like I said, most people, we don't ever have to talk about surgery.
Thank you. If someone has adult degenerative scoliosis and bone-on-bone arthritis in their hip, should they have a hip replacement or fix their back first?
Yeah, this is a really well-studied question that's sort of been a really hot topic in the spine and hip communities over the last decade. And there are a lot of things that go into this. So you can imagine if you had a back surgery and you have really bad hip arthritis, it's going to be really hard to recover from that back surgery because you have hip pain, and it's really important to be able to mobilize after your surgery. Conversely, a big part of degenerative scoliosis is changes in the overall alignment of the spine and pelvis. And so when you have degeneration, oftentimes the position of your pelvis changes. You can imagine that cup that you put in can change based on where your pelvis goes. And so if you put a hip replacement in what you think is a perfect position, but then do a spine surgery and change that position, you can decrease the biomechanical advantage of that hip. And so if you change the cup, you could potentially dislocate your hip. And so now we're leaning more towards doing the spine surgery first. Anyone with a spine fusion has an increased risk of a hip dislocation, but we think we can optimize the biomechanics of that hip if we know the position of the pelvis based on the spine surgery first.
Thank you. Somebody's asking to please spell the name of the physical therapy that can be helpful.
Yeah. So it's called Schroth Physical Therapy, and let me just verify that I spell it correctly. Schroth, Schroth.
Thank you. Once the child completes the required time in a brace while they're growing, are there exercises that they need to do into adulthood? Should they be seeing a doctor and getting x-rays regularly? What's the follow-up care from that? That's
a very good question. And so we decide when to stop bracing when the patient is done growing. And the most accurate way of doing that now that we have is it's a Sanders bone age. And so we do that by an x-ray of the hand. And there are growth plates in every bone in the hand, and we can tell when the patient is about done growing. And so once we stop bracing, I tell the patients, live your life completely normally. If you're having pain, we can do therapy and things to deal with the pain. It may not necessarily be related to the scoliosis. If you wanted to, some people are doing Schroth therapy and they want to continue Schroth therapy. I think that's great because then you're keeping your core strong. You're thinking about keeping your spine as healthy as possible. And usually, I tell patients we should check it again in a couple of years. Maybe come back in 3, 4, 5 years and just get an X-ray to make sure that there isn't any abnormal progression that we weren't expecting. But overall, it's just living your life as if you don't have scoliosis, and then we'll just check it again in several years.
Thank you. Does having scoliosis make you more susceptible to osteoporosis?
So osteoporosis is basically low bone density. And there are a lot of risk factors for osteoporosis. Being a postmenopausal female, there are genetic causes, smoking, certain drugs, a family history, but they're not related at all. If you have osteoporosis and you have a fracture in your back from weak bones, it could potentially cause an abnormal curvature, but having scoliosis does not affect your bone density at all.
Thank you. Is it safe to have surgery for other spine issues when you have mild scoliosis?
Now, that's a really complex and interesting question. It is usually safe. Your spine surgeon, will have X-rays and imaging that will show them the anatomy of your spine. It's important to know the anatomy when you're doing a surgery. And depending on what you do, you may have to take into account the curve when you're doing that surgery. If you're doing, a surgery where you just decompress the nerves or you take out a disc herniation, it won't have much effect. But when you start fusing the spine, you have to make sure that you're fusing it in the correct biomechanical alignment, that you don't end up with more problems later. So even a mild scoliosis, you do have to think about it, but it is safe to have surgery in those situations. It just makes it slightly more complex.
Thank you. What is involved in surgery for scoliosis? Is there one type of surgery or multiple types?
So just like I mentioned, there are multiple types of scoliosis. There are multiple different surgeries for each one of those different types of scoliosis, so it's a complex question. Generally, you have to. It's a bigger surgery than just a one-level surgery because you're addressing a deformity that's going over multiple spine levels, and how you do that varies. Sometimes you can do a surgery all from the back. Sometimes you have to do surgery from the front and the back. Most of the time, it involves a fusion surgery at some point. There are some newer techniques for adolescent surgery or adolescent idiopathic scoliosis called tethering, where you put a flexible kind of rope essentially between the vertebrae to try and modulate the growth. But most of them are a fusion, but how you do it varies pretty greatly. So it's not a simple topic for a short Facebook Live.
Thank you. Is there anything that you can recommend for someone who has pain from adult degenerative scoliosis to do to help reduce the pain?
And so like I mentioned before, there are different things that can cause pain in adult degenerative scoliosis. And so if you have, compression of a nerve because the spine is collapsing and pressing on a nerve, certainly physical therapy for strengthening your core and stabilizing the spine, because a lot of the spine stability are the muscles around it. And so therapy can help. You can take medications, whether, Tylenol, anti-inflammatories. Sometimes there are medications like gabapentin or Lyrica that are specifically for the shooting nerve pain. Certainly if there's one activity that causes pain, I never want to limit people and say you can't do something. But, if the decision is between stopping running marathons or getting a spine surgery, well, maybe we would stop running marathons if that's the only thing that makes it hurt and maybe worth it. There are epidural injections, and so we have our pain management colleagues at OrthoVirginia who do injections, and you can target that one specific nerve that's being pinched. And so there's the pinch of the nerve and then the associated inflammatory response. And so if you put numbing medicine and steroid next to that nerve, you can often get that pain to calm down. And then you don't have to do anything further. There are people who come back 10 years later and say, I had an injection 10 years ago and I've had no pain. Sometimes it only lasts for a short period of time, and then you have to do other things, even consider surgery. And then there's the pain of just your muscles trying to compensate for the deformity. And so that's more muscular pain. And again, physical therapy, strengthening those muscles, working on your posture, sometimes a cane or a walker to give support to those muscles. And so there are a lot of different things we can do to make you more comfortable. But it's really, once you have pain, it's hard to get rid of all of the pain. All of these things are modalities that we use in combination to try and take the edge off and allow you to live your life. I generally don't guarantee people, even with a surgery, that they're going to be pain-free just because of the degeneration they have in their back.
Thank you. Does scoliosis increase the risk of a herniated disc?
There certainly are different forces across discs in a back that has a curve versus a back that doesn't have a curve. Don't think there are any studies that show increased risk of disc herniations with scoliosis, and also the treatment, like we talked about before, is you essentially treat them the same whether you have scoliosis or not, but I don't think it increases the risk of a herniated disc.
Thank you. How does scoliosis impact or interact with arthritis, both osteoarthritis and rheumatoid arthritis?
And so osteoarthritis and rheumatoid arthritis are very different things, even though they both have the name arthritis in them. Arthritis just means inflammation of a joint. And so osteoarthritis is the normal wear and tear of a joint with inflammation. And you can have that in any joint in your body. You can have it in your hips, in your knees, in your shoulders, in your ankles. And so if you're talking about osteoarthritis of your hips and knees, if you're already having trouble because you can't stand up because of your spine, you're falling to the side because of your spine, well then, if your hip also hurts, then that makes you even more disabled. And then you get into the question of, if you are doing surgery, which one are you doing first? Osteoarthritis also is in your back. That's what's causing the degenerative scoliosis. That degeneration and arthritis causes the collapse of discs and the change in alignment of your spine. And so the osteoarthritis is causing the degenerative scoliosis. Rheumatoid arthritis is very different. It's an autoimmune process where your body is attacking your joints. Generally, you don't get as much collapse of discs in rheumatoid arthritis. There are certain conditions associated with the spine with rheumatoid arthritis, but it's usually not scoliosis. But again, if you have joint pain because of scoliosis and you're trying to recover from a scoliosis surgery, it certainly could make things more difficult.
Thank you. Would ice or heat help reduce the pain of scoliosis?
Mm-hmm. It can. If it's from compression of nerves, not as likely, but certainly if you have trouble standing up straight because you're falling forward and your low back hurts, ice at the end of the day may help to calm things down. Potentially, maybe heat at the beginning of the day could help warm those muscles up. And so, yeah, it's definitely worth trying. People always ask me the question, which one should I use? And there's really no study that says one is better than the other. And so I just tell people to try both of them and see which works better for them.
Thank you. That is all of the time that we have for today.
Sure. Thank you everyone for taking the time to be with me today. If you have any questions about yourself or scoliosis, feel free to make an appointment to come see me. We'll go over your x-rays. I'll explain what the curves mean. We can talk about your symptoms and come up with a treatment plan that's best for you. And like I said, most of the times it's not surgery. We try all non-surgical options first. But if surgery is the right thing for you, we can talk about the risks and benefits and make the best decision for you.